in Vancouver General Hospital, Canada. She is the secretary of the Arabian Gulf Skeletal Radiology Society and their representative at the Asian Society of Musculoskeletal Radiology. She is a reviewer at the European Journal of Radiology and Radiographics. She is a lecturer at the Medical School of Arabian Gulf University and a co-lecturer at the National Family Physician Residency Program, Bahrain. So today she will be guiding us and taking us through an approach to imaging of shoulder girdle injuries. So thank you, Dr. Ola, for taking time out and being here to educate everybody. It's a real pleasure to have you over here.
Thank you very much, Doctor, for the kind invitation and the kind introduction. Can you hear me?
Yes, very clearly.
Perfect. Okay, so today we'll be talking about imaging of traumatic shoulder girdle injuries. To start with, they're quite common injuries, especially the ones in acute setting, and they basically depend on the patient's age and the mechanism of injury. All right, imaging plays a quite important role in guiding the surgeon on the next best step. So we can gather a lot of information from imaging. For example, the mechanism of injury itself, therapeutic decision, whether to go conservatively or surgically, decide or manage the post-operative follow-up, and to fish or look for any other associated complications. Now, this talk is basically divided over two lectures. In the first set, we'll talk about proximal humeral fractures and the glenohumeral dislocation, whereas in the next month, we'll be talking about the acromioclavicular injuries, as well as the scapular fractures. All right, to begin with, what basically keeps the peace in this area is a circle of structures, starting laterally with the acromion, moving more medially, acromioclavicular ligament, the clavicle, the coracoclavicular ligament, the coracoid, and the scapula itself, again made of the coracoid and the glenoid, and as well as the articulation with the humerus, basically forming a circle called superior shoulder suspensory complex. Right. So our first part of the talk is the proximal humeral fractures. They're basically quite common, comprising 5.7 of all extremity fractures. They can happen in multiple settings. The most common one happens with a low energy. Usually the patient falls on an outstretched hand, and that's basically an indirect mechanism of injury affecting the elderly osteoporotic females. Whereas the other one basically happens in the setting of high energy trauma, basically in the setting of motor vehicle accidents. And since it's aggressive and it's direct, basically it happens in association with other types of injury, such as glenohumeral dislocation, and it affects young individuals. Or it can happen due to excessive shoulder muscular contractions in the setting of seizures and electrical shocks. Now, radiographs can provide us with like a valuable set of information. So starting with anatomy, we know that the humeral head, most importantly, we have the greater trochanter, the greater tuberosity, lesser tuberosity, the anatomical head, which articulates with the glenoid. Now, this is the surgical neck of the glenoid, whereas this is the anatomical neck, and this is the coracoid. We can see these anatomical structures on the regular frontal radiograph or the Grashy view, which is called the true AP radiograph, or we can also see them on axillary view, which we'll talk about these views in a bit of more details in the upcoming slides. All right, so touch base on some mechanism of injury. Usually it happens when the patient falls on outstretched hands. For the spiral fractures or shaft of the humerus fracture, this happens when there is external rotation of the body in contrast to internal rotation of the humerus. And that's how the spiral fractures involving the mid shaft of the humerus occur. As for proximal shaft of the humerus fractures, basically it happens in the setting of hyperabduction. So again, full on outstretched hand, the arm is extended and abducted. And basically what happens, the greater tuberosity will impact on the acromion. And that will result in greater tuberosity fractures as well as surgical mid fractures. Right. Now, our main players for proximal humeral fractures are these four. We have the greater tuberosity, lesser tuberosity, anatomical neck, and the surgical neck. In order for us to decide the types of proximal humeral fractures, they're basically divided into four parts, depending on the number of players, which we talked about earlier, the greater tuberosity, lesser tuberosity, humeral head, and shaft involved. So the number of displaced or angulated fragments will tell us what tell us the severity of injury we're dealing with, and hence the classification. And for this type, we depend on near classification. All right. So in order for us to make this diagnosis, let's start with radiographs. We have the bread and butter, which are usually the conventional radiographs. We have the frontal view, which is good to look at these anatomical structures, which we have spoken about earlier. We also have the Grashy view, in which it basically removes the overlap between the humeral head as well with the glenoid. So basically you can see the distance, and it's good to fish for any fractures or injury within this area. We also have the Y or scapular view, which is we're basically looking at the shoulder from the side, which is very useful in the setting of dislocation, in which your compass is either the acromion, if the humeral head is dislocated this way, we're dealing with posterior dislocation, or the coracoid, which is located anteriorly. If the humeral head was dislocated this way, we're dealing with anterior dislocation. And we also have the axillary view. Okay. The rule of two in radiology: never ever make your diagnosis based on one view, because it could be quite deceiving. All right. So two views and above, otherwise you cannot make the diagnosis. All right, let's talk about other method of imaging, which is the CT. It's important to evaluate morphological features, degree of displacement, in case there were any other associated injuries such as the glenoid or scapular injuries. It's a good prediction for a humeral head ischemia, and it's good for preoperative planning. Right, as you can see in this example, we have fracture, displaced fracture involving the anterior aspect of the inferior glenoid, in keeping with Bankert lesion. MRI is good to look for occult fracture because edema is your guide. Also, it's good for evaluation of rotator cuff injury, which usually occur with high impact injury involving 3 or 4 parts, or displaced greater tuberosity fractures. Ultrasound, or especially Doppler sound or angiography, is quite useful to evaluate the vascular structures, because they could be compromised in high impact injury, especially with the markedly displaced fracture. And of note, we have the axillary artery. All right. So in order for us, now we're talking about near classification. In order for us to say that this qualifies to be one part, this fracture fragment needs to be displaced by more than 1 centimeter or angulated more than 45 degrees. All right. So remember, based on that fact, the total number of fracture fragment does not necessarily correlate with the actual number of the fracture parts, because they have to fulfill that criteria. It has to be displaced more than 1 centimeter or angulated more than 45 degrees. All right. Again, remember our main players: the greater, lesser tuberosity, humeral head, and humeral shaft. All right. Let's start with example. Starting with one part fracture, even though you do see fracture lines, but since none of these parts is displaced more than 1 centimeter or 45 degrees of angulation, then this is a one-part fracture, because we're seeing the bone as in one entity. So it's either non-displaced or minimally displaced fractures. Luckily for us, these are the most common types of proximal humeral fractures, and they're almost always treated conservatively. As you can see in this example, we have an impacted fracture involving the surgical shaft. And this is another example of minimally displaced fracture involving the anatomical head, both of which are not displaced more than 1 centimeter, both of which are not angulated more than 45 degrees, and therefore they would make type 1 near classification proximal humeral fracture. All right. This is an example of a 75-year-old female that fell while gardening 6 days earlier and she was unable to move her arm. As you can see in this example, we do see a greater tuberosity fracture. There is a fracture involving the greater tuberosity as well as the surgical neck. However, and this is both basically seen on the frontal view as well as the Y view. However, none of these fractures is displaced more than 1 centimeter or angulated more than 45 degrees. Even though it looks quite significant on the radiograph, even though it doesn't look, quite looks nasty, it still qualifies to be type 1 because all these fragments are not displaced more than 1 centimeter or angulated more than 45 degrees. All right. As for the two parts fracture, basically, one part is displaced more than 1 centimeter or angulated more than 45 degrees. Most commonly, it affects the surgical neck, followed by the greater tuberosity, the greater tuberosity, and usually this happens in the setting of anterior shoulder dislocation, followed by anatomical neck, and uncommonly it involves the lesser tuberosity. These basically make 20% of proximal humeral fractures. So as you can see in this example of a 60 years old female that fell at home, there is a fracture that involving the surgical neck with complete displacement of the head of the humerus. And this based on our criteria, this qualifies to be type part 2, which was basically treated with plates and screws fixation. If the two parts fracture affects the greater tuberosity, then it's quite aggressive. And as I said mentioned earlier, it does if it goes down, it doesn't go down alone. It takes other structures with it down. So basically, there could also be anterior glenohumeral dislocation or also rotator cuff injury or tear. Three parts fracture. So now we have two parts that are displaced more than 1 centi or angulated more than 45 degrees. So either we have greater tuberosity in alliance with the shaft, that's the most common method, or it could be the lesser tuberosity in conjunction with the shaft. And they basically make up 5% of proximal humeral fractures. These are most commonly treated with open fixation if surgery was appropriate for the patient. As you can see in this example, we have three parts. We have the shaft, we have the greater tuberosity, and we also have the humeral head. Last but not least, we have the four-part fractures. So three parts are displaced more than 1 centi or angulated more than 45 degrees. Luckily for us, they're quite uncommon, making less than 1% of proximal humeral fractures, and they usually have poor non-operative results. Why? Because the articular surface is no longer attached to any parts of the humerus. So the patient has high likelihood for osteonecrosis. So the patient has high likelihood of osteonecrosis, and also, even though it requires surgery, it's mostly associated with poor, with high risk. And of course, as we said, poor non-operative results. As we said earlier, they're most commonly treated with open fixation if surgery was appropriate for the patient. This is an example of a 65-year-old female with proximal humeral fractures. As you can see, there is complete dislocation of the humeral head. It's a comminuted fracture involving the greater tuberosity as well as impaction at the level of the surgical neck. With CT, as you can see, as further subdivision or the fragments, the surgical neck, the greater tuberosity, the humeral head, and the lesser tuberosity. So lesser tuberosity could be easily missed on radiograph. So therefore, this is just to further emphasize the importance of the use of ultrasound because it brings other structures that are involved into life. And let's say a rule of the thumb, if usually we have complete dislocation of the humeral head, usually there is a fracture involving the greater as well as the lesser tuberosity. Even though we don't really see it well on the radiograph, that should raise our suspicion and move next with cross-sectional imaging, such as CT scan. All right. Since we're talking about the classic near classification four-part fracture, I have to also touch base and talk about valgus impacted four-part fracture. This is quite different than the classic near classification for four-part fracture. In the valgus impacted, usually the glenohumeral articular surface is spared, so it's preserved rather than dislocated, in contrast to the classic four-part proximal humeral fracture. So, in other words, I'm trying to say if there was involvement of the articular surface, this is a higher degree of injury, this is more severe with worse prognosis. So it's important for us to identify the valgus impacted because the management will be different. Valgus impacted basically, again, the articular surface is spared. In terms of management, we can either do closed reduction or limited open reduction with minimal internal fixation, with usually 75% or 74% of satisfactory results. This is a comparison between the four-part classic near classification fracture. Again, as you can see, there is involvement of the articular space with interarticular extension, whereas in the valgus impacted, the articular surface is quite preserved, making the rendering the prognosis better than the classic four-part near fracture. All right. There is a huge difference between fractures with valgus alignment and varus alignment. Fractures with varus alignments carry a worse prognosis. It was found that varus alignment carries a worse prognosis compared to the normal, and thus you would have higher risk of avascular necrosis. Why? We will be talking about this in further details in the upcoming slides. All right. Near classification is not perfect. It comes with its flaw. Number one, it's quite vague. It is operator dependent. I mean, you might say something, you might see it in a way, another person might see it in somewhere else. And sometimes it doesn't quite make sense. So, if there was an avulsion fracture of the greater tuberosity that is displaced by 1 centimeter, this qualifies to be a two-part fracture. Whereas, if I had a 9 millimeter greater tuberosity and a 9 millimeter surgical neck fracture, if I put them together, that will basically be one part because none of them was displaced more than 1 centimeter. So sometimes that doesn't really make sense. Also, the near classification does not cover interarticular extension, articular split, and osteochondral impaction. This is quite important to decide on the management and also the prognosis. And last but not least, as we said, it has poor intra and inter-observer reproducibility. All right. Now, when we talk about intercapsular fractures of the proximal humerus, we need to talk about, it's important to understand the blood supply to this area. Usually, the blood supply in this area happens in a retrograde fashion, from distally to proximally. And it's important to identify fractures in the area where the blood vessels run. So, where are the areas that I have to pay extra attention to? Number one, we have the anatomical neck. Number two, the four-part fractures involving the greater and the lesser tuberosity. Why? Because, as we said earlier, if I had a fracture involving the greater tuberosity as well as the lesser tuberosity, we have high likelihood of having displaced humeral head fracture or proximal humeral head dislocation. Also, comminuted articular split fractures carry a worse prognosis than the rest of the fractures. So basically, we need to pay extra attention to these three types of fractures. All right, so blood supply to this area. We have the axillary artery. Axillary artery gives off anterior circumflex. Anterior circumflex gives off the arcuate. The arcuate supplies the humeral head by traveling along the intertubercular groove. We also have extra supply from the rotator cuff, but let's go back to the axillary artery. So anterior circumflex, posterior circumflex, and it travels up along with the axillary nerve. Now, The area where the anterior and the posterior circumflex artery comes off the axillary is basically located 8 millimeter from the articular surface. So this is my area of danger zone. This is the area where I have to pay extra attention and look for any fracture line extension, because involvement of fractures in this area will tell you that the patient will have high likelihood of a vascular compromise and thus high likelihood of osteonecrosis. All right. So it's important to include it. Disruption of the medial aspect of the proximal humeral head has to be included in our reports. All right. So so vascularity of the articular surface is more likely to be preserved if my fracture line was found more than 8 millimeter of the articular surface. Now, what are the predictors of humeral head ischemia? If this fracture line was located less than 8 millimeter from the articular surface, if I had disruption of the medial hinge, as you can see in this example, there's disruption of the medial hinge. This is basically displaced, whereas this one is not displaced. So the displaced one, consequently, will have or carry worse prognosis. Increasing in the fracture complexity, basically if we're dealing with a comminuted fracture, and displacement that it's more than 1 centimeter, and angulation more than 45 degrees. All right, let's talk about the articular split fractures. Now, these are the fractures that involve the articular surface. They come in two flavors. They could be simple, basically we're dealing with one fracture line, or they could be comminuted. By default, there are two more fragments. Now, the fractures that are extending through the articular cartilage are difficult to reduce and carry a worse prognosis that increases with the patient's age. This is an example of a woman who was involved in a high-speed motor vehicle accident. As you can see, there's a proximal shaft fracture, and there is also a thin line of fracture that basically extending into the articular surface. This is an example of another patient, 60-year-old, was involved in a bicycle accident. We have an impacted, or basically it's a comminuted impacted fracture involving the surgical neck. And it's also seen involving the greater tuberosity as well as the lesser tuberosity. And again, further emphasizing the importance of use of cross-sectional viewing such as CT in order to fish or look for other associated bony involvements. All right. So in conclusion, the dangerous fractures are the ones that are involving the anatomical neck. Basically, any isolation of the anatomical neck would result in isolation of the anatomical neck from capsular attachment, and thus it will increase the likelihood of a vascular necrosis. Fracture that are separating the greater and lesser tuberosity will result in isolating the anatomical head from the rest of the humerus, and thus increasing the likelihood of a vascular necrosis. And as we said earlier, fractures that are involving the medial periosteum, especially the 8 millimeter from the articular surface, will increase the risk of osteonecrosis. So it was found that a combination of these fractures had a positive predictive value of ischemia in 97% of patients. This is an example of a 58-year-old man who was injured while skiing. As you can see, we have an isolated anatomical head fragment. Why? Because there was a fracture involving both the lesser tuberosity and the greater tuberosity. And as you can see, the anatomical head is displaced laterally. So basically, this will carry a worse prognosis and high likelihood of a vascular necrosis or osteonecrosis. Again, fractures that are seen in the high-setting injury, especially the ones involving greater tuberosity, are seen to be highly associated with glenohumeral dislocation, and they could also be associated with articular head fragment that basically displace into the axilla. We have to pay attention because they can result in instability, pain, hydrotopic ossification, and neurovascular compromise. And most of the time, or of course, if not exclusively, would require surgical intervention. This is an example of a 23-year-old man who was involved in a motorcycle crash. Again, as you can see, we have a fracture. This is a comminuted fracture involving the greater tuberosity, surgical neck, lesser tuberosity. As a rule of the thumb, greater tuberosity is involved, lesser tuberosity is involved. We would have high likelihood of dislocation of the anatomical head. And because of that, that's a 1 year follow-up. As you can see, there was heterogeneity, increased density, and irregularity involving the humeral head compatible with osteonecrosis. This is another example of a 69-year-old man with pulseless upper extremity after a ground fall. As you can see, there is a fracture involving the surgical neck, posterior displacement of the anatomical head, and with an angiogram, you can see we have narrowing of the axillary artery. So what I wanted to say that these fractures could be associated with neurovascular compromise. As you can see in this example, the axillary artery, and this patient was later treated with stent placement. Since we've been further emphasizing on the vascularity, the integrity of the vascular supplementation, they came up with a classification that will tell you the likelihood of a vascular necrosis. Right. The name is quite hard for me to pronounce, but as you can see, the AO classification. Now, basically, we have A, B, and C. In part A, it basically is an extra-articular fracture with unifocal involvement. So there's only one side. It depends what it involves and with or without impaction. Type B, it's extra-articular, still extra-articular, but we have two areas of involvement and thus bifocal fracture. It could be with metaphyseal impaction, without metaphyseal impaction, or with displacement and dislocation. And type C, basically when it involves the articular fracture. So the higher the number, the higher the level, the higher is the likelihood of undergoing or resulting in a vascular necrosis. So in summary, factors that are predictive of ischemia are anatomical neck fractures, all right, especially when we have involvement of the greater as well as the lesser tuberosity, medial metaphyseal segment, especially when you have a disruption of the periosteum less than 8 millimeter from the articular surface, or when we have displacement more than 2 millimeter. So the cortical thickness around the fracture has to be reported. Why? Because later on, when the patient undergoes surgical fixation, in order for the screw to be stable and not migrating, you need the thickness of at least 4 millimeter of a cortical around the fracture line. All right. As we said, most of the proximal humeral fractures are type 1. Type 1, minimally displaced or non-displaced. Luckily for us, most of these patients will undergo a conservative treatment is more than enough. When we talk about surgery, the decision is multifactorial, depends on so many factors. Patient's age, bone quality, rotator cuff status, the bone stock, the fracture severity, any other morbidities, and of course the functional the assessment of the patient. All right, complications. We talked about neurovascular compromise. When we talk about nerves, in some patients, they can have permanent motor dysfunction. Of note, we have the axillary nerve affecting 58% of cases, followed by suprascapular nerve affecting 48% of cases. We have vascular injuries, as we saw in the prior example, affecting the axillary artery. And they could also be associated with brachial plexus injury. Adhesive capsulitis, especially the patient comes 5-10 years down the line with severe pain, sudden severe pain with loss of range of motion, keeping with adhesive capsulitis. And with high severity fracture, we can have osteonecrosis in around 33% of these cases. Surgical option would involve or include plate and screw fixation, intramedullary nailing, tension band construction, and hemiarthroplasty or reverse total shoulder arthroplasty. This is an example of plates and screw fixation. Usually they utilize this when we have greater tuberosity fractures that are displaced more than 5 millimeter or head splitting intra-articular fractures. Intramedullary nailing, usually done in the setting of proximal humerus and shaft fractures, surgical neck fracture, or greater tuberosity fractures. This is an example of tension band construction, and this is an example of hemiarthroplasty. There are post-operative complications that we have to put in mind. For example, especially if these patients came for follow-up, whether on radiographs or cross-sectional imaging. Number one is screw penetration, usually when the screw cuts off through the humeral head. In the setting of open reduction internal fixation, that usually is seen in 3 to 16% of cases. Humeral head avascular necrosis, chronic instability after arthroplasty, especially if it was associated with other types of injuries, and loss of the range of motion, or in other words, capsulitis. So, in summary, when we're reporting a case of proximal humerus fracture, number one, we need to decide whether it was displaced more than 1 centimeter or 45 degrees in order for us to decide on the near classification. Number two, we need to know whether there is an intra-articular involvement. Is it simple or is it comminuted? Number three, we need to decide if there is anatomical nut fracture or fracture that are involving the greater and lesser tuberosity. Why? Because as we mentioned earlier, involvement of these structures would increase the likelihood of avascular necrosis. Number four, if there was an anatomical neck fracture, then length and displacement have to be measured. Remember the rule of 8 millimeter. If it was less than 8 millimeter from the articular surface, or if it was displaced more than 2 millimeter, then you're dealing with a case of high likelihood of avascular necrosis. And last but not least, the presence of concomitant glenohumeral dislocation. And in case that happened, we need to decide on the direction and the location of the articular fragments. So it's important to decide on the presence of intra-articular loose bodies because they can hinder reduction and thus accelerate osteoarthritis. We're done with our first part of today's lecture. Second part is glenohumeral dislocation. Now, the glenohumeral joint is basically made of the articulation of the glenoid with the humerus. The glenoid covers 1/3 of the humeral head articular surface. And basically, the joint capsule is lax. And because it's lax, it's susceptible to instability and it's prone for dislocation. 50% of these dislocations occur in young men, and in 90 to 95% of the cases, there are anterior dislocation. 2 to 4%, or let's say 5 than 5%, they're involving, or basically are posterior dislocation, and in less than 1% are inferior dislocation or luxatio rectum. As we said, the glenohumeral joint is made of articulation of the glenoid with the humeral head, basically like an ice cream cone sitting on top of the biscuit or the cone itself. All right. Anterior shoulder dislocation affects young male. It can also affect elderly. The cause of injury is forced abduction with extended rotation and extension. The humeral head will be dislocated anteriorly, medially, and inferior to the glenoid fossa. Usually, as we said, it happens in setting of high energy impact. When this happens, there are further other injuries that could be associated with it, such as Hill-Sachs lesion and Bouchard lesion, which we will be talking about in further details shortly. As you can see in this example, the humeral head is dislocated anteriorly and inferiorly to the coracoid. Again, anterior to the coracoid as well as anterior and inferior. We can make this diagnosis on the AP or frontal view as well as the scapular Y view. Remember, your bones are your guides. Posteriorly, we have the acromion. Anteriorly, we have the coracoid. If it moved anteriorly, basically it will be below the coracoid, thus anterior dislocation. If it moved in this direction, inferior to the acromion, then we're basically dealing with posterior dislocation. As we said, usually these injuries happen in association with other injury. For example, if I had posterior lateral impaction of the proximal humeral head while dealing with Hill-Sachs fracture. If I had a fracture or bone injury involving the anterior inferior aspect of the glenoid, then we're dealing with Bouchard fracture. And again, these happen in association of anterior shoulder dislocation. So what happens? The shoulder is dislocated anteriorly and medially as it rotates. The posterior lateral aspect of the proximal humeral head impacts on the anterior aspect of the glenoid. So this will form the pancreatic lesion, and this will form the Hill-Sachs lesion. One of the useful radiographic view in order to make this diagnosis is axillary view. So it's basically an axial view. Again, anteriorly, we have the coracoid, that's my compass. Posteriorly, I have the acromion. So if the humeral head moved this way, that's anterior dislocation. If it moved this way, then this is posterior dislocation. However, before making this diagnosis, you need to ensure that it was the correct view because it could be misleading. One of the useful tips to know that it was taken in the right technique is the presence of eye sign. So if we saw the eye sign, that you know this is a true axillary view. If it was not, then you cannot make your diagnosis on that view, and you basically have to repeat or maybe perform another view. Another useful view for cases of for when we come to evaluate anterior shoulder dislocation is the Bernard-Jault glenoid profile or the West profile view. This is quite useful for recurrent anterior instability, posterior instability, post-operative assessment following the coracoid transfer procedure, which we call letter J. Basically, the tube will be angulated 60 degrees to the torso. So, as we said, it's very good for evaluation of post-operative letter J procedures when we want to correct the pancreatic lesions by insertion of a screw, and we will talk about this in details in the surgical part. And so basically, it gives a beautiful representation or an overview of the anterior and posterior aspect of the glenoid. Also, it's good to evaluate or look for bony loss. As you can see in this example, this is a normal glenoid, whereas it's a kind of a chopped off or blunted glenoid in keeping with a pancreatic lesion. So this is what we call a cliff sign or a blunted ankle sign when part of the bone is chopped off or blunted. So it makes it easier for us to evaluate or suggest a pancreatic lesion in case we were working in an area where the reach of cross-sectional imaging was not that direct. So it's good to give us an idea of what's happening. All right, this is an example of anterior radiograph with internal rotation, post-reduction. As you can see, we have impaction fracture or depression involving the posterior lateral aspect of the humeral head, and that would in keep with Hill-Sachs lesion. This is another view, which is called a striker notch view, which is very good to look for or fish Hill-Sachs lesions, especially if we are not able to see them on the regular, whether the frontal internal or external rotation radiographic views. And this is another example of Bernard-Jault view with blunted anterior glenoid in keeping with pancreatic lesion. CT is good to help us further understand the injury mechanism of injury, the injury morphology, fish for any intra-articular bodies, any associated pathology, and of course the degree of bone loss. All right. So in this example, as you can see, so what I want to say that the CT is not only useful to see the injury, but also it gives us a good overview in case we were dealing with congenital problem. For example, when you have a glenoid dysplasia, as you can see, this is a posterior glenoid dysplasia. This basically increases the risk of posterior dislocation. In this example, you can see the bony defect involving the posterior lateral aspect of the humeral head in keeping with Hill-Sachs. In this example, you see a bony pancreatic lesion with a displaced fracture involving the anterior inferior aspect of the glenoid. This is an engaged pancreas with Hill-Sachs. As you can see on a 3D representation of the CT. And this is an example of a posterior dislocation as seen on the cross-sectional imaging. All right. PICO or PICO method is good to evaluate or understand the amount of bony loss. So basically, we can calculated from the following formula. So basically, you draw a circle, then you measure the width of the amount of the bony that is lost, and then you measure the width of the normal bone. By following this formula, you can understand the percentage of the bony loss. So if I had more than 25% of bony loss, this will mandate surgery because it will increase the less risk anyways for a worse prognosis. All right. In some literature, they're quite more aggressive, and they recommend any 20, and like if there was more than 20% loss, then that would carry more serious prognosis. Okay. This is an example of a Bankart lesion, as you can see on the sagittal CT. Again, representation of the hill sac with the bony Bankart lesion. This is an example of a 42-year-old patient who had anterior shoulder dislocation. They had multiple attempts to relocate. They couldn't. The patient underwent a CT scan. Surprise, surprise. The reason of the failure was the presence of multiple intra-articular loose bodies. So it's important to mention these in our reports. It's also, if we had a high suspicion, to move ahead, a step ahead, and order a cross-sectional, such as a CT scan, to look for these lesions, because they will prevent a reduction, and they will also accelerate the process of osteoarthritis. MRI is quite useful to evaluate the labrum, the size, the location, the injury of scapular periosteum, and the cartilage as well. This is a hill sac lesion, as seen on the MRI, and this is both bony and soft tissue Bankart. As you can see, we have loss of the bony anterior inferior aspect of the glenoid, and there's the attachment of the anterior inferior labrum. All right. When I talk about these types of injury, it's important to say whether these hill sac and the Bankart are engaging or non-engaging. Why? Based on my understanding, it will guide me for the next best step or even the management. In order for us to say whether it's engaging or non-engaging, we need to calculate two important variables. Number one is the hill sac interval. How do we measure it? So basically, we do the transverse width of the bony loss, which is basically the posterior lateral aspect of the humeral head, as well as the distance between this defect and the site of insertion of the rotator cuff. Now, a rule of the thumb, before we jump and say, oh, that's a hill sac lesion, remember to always do your measurement at the level of the cricoid. Because if we move a little bit more inferiorly, that will not be the hill sac lesion. That will be the physiological depth for the site of insertion of the infraspinatus. So remember, in order for us to call it a hill sac, it has to be at the level of the cricoid. So for the hill sac interval, we measure the width of the bony loss, as well as the distance from the bony loss to the site of insertion of the rotator cuff tendon. Our second variable is the glenoid tract. In order to measure the glenoid tract, you need to draw a circle, measure the entire width of this circle. So basically, we're looking at the glenoid from the lateral view, sagittal view. So you measure the entire width, and you draw another line trying to measure the amount of bony loss. And basically, you follow this formula: 0.83 by the whole width minus the bony loss. Okay. So in order for us to decide whether they're engaging or not engaging, on track or off track, we need to calculate these two variables: hill sac interval as well as the glenoid tract. Now, if the hill sac measured more, the hill sac measured more than the glenoid interval, then basically you're dealing with an engaging off-track hill sac defect. However, so basically what that means that the defect, the hill sac defect is quite big, and it gives it leverage to move wherever it wants. And basically the patient will keep having recurrent dislocation. It move and it will move back. It will move forward and it will move back. And with each time, it can result in further injury and pancreatic lesion. Whereas the non-engaging on-track Hill-Sachs defect, the Bankart, the glenoid interval will measure more than the Hill-Sachs interval, and basically it's quite more stable. Now, when we talk about shoulder instability, most of the cases happen in the setting of shoulder dislocation. So when we talk about anterior shoulder dislocation, we have to, other than the Bankart lesion, we have to talk about other types of labral injuries, because the labrum, injury to the labrum, could be associated with instability of the shoulder. Now, injury of the labrum can occur in many flavors. Now, if we have torn labrum but an intact periosteum, we call that perthes. If we had a torn labrum with disruption of the bone, disruption of the periosteum, then we call that Bankart lesion. Bankart lesion occur in two flavors. It could be soft tissue Bankart, or it could be bony Bankart, in which it chops part of the bone with it. Or we have ALPSA, when it's basically medialized perthe. So basically, we have disruption of the labrum. However, it medially localizes, and the periosteum is still intact. GLAD is basically when we have articular extension, and the literature showed that the GLAD lesions don't increase the likelihood of instability. But I just thought of mentioning it since we're talking about types of labral injury and what are they associated with. Slap injuries are also associated with instability. So basically, as the name entails, it's superior labral anterior-posterior tear. Best seen on the, basically I use all views to diagnose it. As you can see, this is how it looks like on the coronal. There is loss of the black triangular appearance on the coronal view. As you can see, there is high signal intensity line moving all the way from anteriorly to posteriorly on the most superior aspect of the labrum. And depending on what other structures are involved, the amount of involvement, we have different types of slap tears. So treatment-wise, anterior and posterior instability, most of the cases will require surgical repair as well as strengthening of the capsule. So physio. Multi-directional instability, most of the time it does well with conservative management with rotator cuff strengthening exercises. And as we said, as we talked earlier, about the engaging and non-engaging Bankart as well as Hill-Sachs lesions. All right. So in case I had a large bony defect within the glenoid, we need to fill this defect. So one of the ways to do it is the letter J procedure, in which there is a removal of the cricoid and reattachment of the cricoid within the bony defect within the anterior glenoid, and thus to decrease the likelihood of instability. As we can see, we remove part of the cricoid, and this is basically further screwed into the anterior aspect of the glenoid. And as we said earlier, the Bernard-Jault or West profile X-ray radiograph view are quite useful to evaluate these post-operatively. Now, if the Hill-Sachs lesion was bigger than the Bankart or the glenoid defect, we need to fill this defect. And one of the ways we do that through the remplissage procedure, in which you fill this defect with the infraspinatus tendon. Quite like a puff pastry, the filling in this setting will be the infraspinatus tendon rather than food. Complications in the setting of anterior dislocation, we have recurrent instability, making it ranges from 14 to 100%, damage to the inferior glenohumeral ligaments, axillary artery involvement, or brachial plexus injury. Last but not least, we have posterior shoulder dislocation. These make around 10 to 5% of shoulder dislocation. The humeral head will dislocate posteriorly, usually happen in a high-setting trauma and seizure of electroconvulsive treatment, and what we would have reverse bony Bankart and anteromedial impaction fracture of the proximal humeral head, which we call reverse Hilsa. So again, the humeral head will dislocate posteriorly. The posterior aspect of the glenoid is involved, that's reverse Bankart, and the anterior medial aspect of the humeral head is involved, and that's a reverse anterior medial aspect, that's a reverse Hilsa. Now, these are quite tricky to diagnose on radiographs. So I tried to include a couple of useful tricks in order for us to diagnose this entity. So, number one, what happens? The patient will be in fixed internal rotation. Because the patient is in fixed internal rotation, it will gives me the famous light bulb sign or light bulb appearance. How do I like what do I need to see in order to call it that? We know that in the true AP view, there should be normal overlap, which we call the half moon sign between the humeral head and the glenoid. Whenever I have loss of this overlap sign, a widening of the glenohumeral joint, this is basically a light bulb sign. So, in other words, this will resemble a Grasha view. Grasha view is when we do like it basically happens with slight angulation of the tube on this area, and it basically done to remove the overlap between these two bones. So make sure before calling it a light bulb sign that the technician did it as a frontal view rather than a Grasha view. We don't want to misdiagnose it depending on a technical fault. So when we have on our AP radiograph, when we have a light bulb sign, loss of the half moon overlap and widening of the glenohumeral joint, we would suspect posterior dislocation. Also, as we said, posterior dislocation, when it happens in association with other injury. As you can see, this is a Grasha view. When we obtain a Grasha view, we should have no overlap between these bones. But as you can see in this example, there is overlap between the humerus and the glenoid. Basically, we're dealing with something abnormal. Not only that, we see another line that's a vertical line that is seen anterior to the glenoid, and that's basically the displaced fracture of the anterior medial aspect of the humeral head, which we basically call reverse Hillside lesion, which we call TRO sign. Another useful tip in order to diagnose posterior shoulder dislocation is disruption of Maloney line. Just like in the hip, you have the Shenton line, you have Maloney line in the shoulder. So basically, this should form a smooth, continuous line between the medial aspect of the scapula with the medial aspect of the proximal humerus head or neck with the scapula. If you have a disruption of this line, then suspect posterior shoulder dislocation. So, and never forget to utilize your extra tools in radiology or in radiographs. For example, the axillary view and the Y view, in which you use your osseous landmarks as your guides. Acromion, as you can see, the humeral head is dislocated inferior to the acromion. So in other words, we're dealing with posterior dislocation rather than the humeral head being superimposed on the glenoid in the middle. It's also important on cross-sectional view to evaluate or assess the amount of bony loss. Why? Because the amount of bony loss will tell you whether you will have a high likelihood of instability, and thus the management will differ. So one of the nice view, and like let's say fun ways to roughly evaluate the amount of bony loss is the CCAG view. So basically on the axial cut on the CT scan, you drew a line that basically runs through the middle aspect of the humeral head all the way from anteriorly to posteriorly. You drew another perpendicular line to the articular surface. So as you can see, this will make 50% of the articular surface. And you draw another line that is that cuts this 45 degrees into two halves. So if I had a fracture with a bony defect involving this area, I can easily and safely say, oh, this is involving 25 degrees of the articular surface, just in a way to predict. All right. There are a set of, let's say, anatomical variants that can predispose for posterior dislocation and thus instability. One of which is glenoid dysplasia. What happens is that there would be an underdevelopment of the inferior glenoid ossification center. The glenoid has two ossification centers, superior and inferior. When the inferior one would underdevelop, the patient will have glenoid dysplasia. And as a compensatory mechanism, there will be a hypertrophy of the labrum as well as the ligament or actually the cartilage. In order for us to diagnose that, we need to measure the glenoid retroversion. So what do? Basically, we do that on axial CT scan. You draw a line that goes through the middle aspect of the glenoid bone into the medial tip of the scapular blade. Then, and that what we call the scapular line. Then you have to draw you have to draw the glenoid line, which basically runs all the way from the anterior to the posterior aspect of the margins of the glenoid line. And then you basically measure the angle between these two lines. This should be between 0 and 7. It was more than 7, then we have high likelihood of posterior dislocation and thus posterior labral injuries as well. Sometimes on the MRI, we might not see the tear, but we can see things that will tell us that there could be an occult tear. So for example, as you can see, we have perilabral cysts that are seen posteriorly. Also, if you notice, the posterior aspect of the glenoid is underdeveloped. As you can see, it's hypoplastic in comparison to the anterior aspect. So we basically have glenoid hyperplasia. As a compensatory mechanism, when we have glenoid hyperplasia, we will have compensation from the overlying glenoid or the cartilage. So as you can see, the glenoid over here is hypertrophied in comparison to the anterior labrum. Right. So posterior dislocation could be associated with reverse Bankart lesion. Usually, we have impaction fracture involving the intermediate aspect of the humeral head, as you can see. This is another example of reverse Bankart fracture. There's disruption of the periosteum and a cut of the labrum as well, posterior. Treatment of posterior dislocation depend on the size, duration, patient factors. So remember why we said earlier we need to measure the amount of bony loss and involvement of articular surface, because based on that number, I would know, or the surgeon would know what to do with the patient. So if usually the injury is stable, it's fresh, less than 3 weeks, acute, and there is less than 25% involvement of the articular surface, then patient would more likely go under a closed reduction. But if it was unstable or reducible, the patient more likely to undergo a open reduction. Injuries that are involving 25 to 5% of surface area would require a transfer of lesser tuberosity to fill the defect, like we do with letter J, with the glenoid fracture. This is a similar thing that could be done with the use of lesser tuberosity. And of course, shoulder arthroplasty is reserved for more severe injuries and when we have defects more than 50 degrees. All right. Posterior shoulder dislocation, usually glenoid and capsular injury can occur, and that would predispose for chronic posterior instability. And especially in older patients, they could be associated with rotator cuff injury. So always remember to, if you're evaluating the radiograph, to measure the acromihumeral interval, because it could be an indicator of involvement or abnormality happening within the rotator cuff. Last but not least, a less entity of dislocation, we have flexure recta. Usually that happens in the setting of abducted arm with inferior medial displacement of the humeral head. How can we differentiate this entity of a subglenoid anterior displacement? Is basically the humerus will be parallel to the line of the scapula, and basically it's clinically they will the diagnosis is made on clinical grounds. All right. To summarize, if we're dealing with a case of dislocation, in our reports, we need to describe the direction of dislocation, the presence of any associated fracture involving the humeral head, either proximal humeral fractures, glenoid fractures, or Hill-Sachs fracture. And of course, if we could tell the percentage or amount of the area that's involved. So the questions to be answered: what are our report checklists? Is the humeral head abnormally positioned in relation to the coracoid or not? Anterior or posterior dislocation. Is there an associated Hill-Sachs fracture or not? And if so, we need to measure. Is there an associated Bankart injury? And we need to measure. And of course, we need cross-sectional imaging, especially MRI, to decide if there any associated labral injury. And we can further tell if articular cartilage is involved, bony periosteum is involved, and inferior glenohumeral ligament, because the inferior glenohumeral ligament is quite important for shoulder instability. And most of the time, this diagnosis is made on the setting or the performance of MR arthrogram. And of course, don't forget to mention if there are any intra-articular loose bodies, because it will hinder fixation or relocation. Plus, it will accelerate osteoarthritis. And of course, last but not least, if there are any other associated rotator cuff or tendon injuries. And that should mark the end of our first lecture.
Thank you so much, Dr. Rola. It was so interesting and engaging. So there are few queries I think which you have actually already covered up, but I'll just read out a few of them to you. Even you can have a look at the Q&A section.
Okay, sure. Q&A.
So
Yeah.
I think the first one is if a fracture fragment is displaced less than 1 centimeter or angulated less than 45 degrees, do we call it a part 1 fracture?
Yes. So, okay. Now, there's one more thing I forgot to mention. It's good. It's good that we have all these classifications, but in our reports, we don't actually have to mention a classification. It depends on the surgeon you're dealing with, because sometimes they don't use the same terminology we do. So the use of these guys, like let's say the classification system, is to tell us what to include in our reports. Plus, as we mentioned earlier, the near classification has its flow. But as a rule of the thumb, yes, if it was less than 1 centimeter, less than 45 degrees, it's either minimally displaced or non-displaced, so it's part 1 fracture. Why is it important for me to know it's type 1? Because it will tell me it will have a better prognosis and it could be treated conservatively. So that's for first question. I hope it's clear.
Yeah. The second one is how to differentiate a Hill-Sachs defect from a normal defect.
Yes. Okay. So the health sac, basically, when we have a posterior lateral impaction or bony loss involving the proximal aspect of the humerus, we said as a pitfall, when we make this diagnosis, it has to be done, especially on the axial cut of CT or MRI, on the first couple slices. And as a rule of the thumb, do it at the level of the cricoid, because if you go lower, then that will be the normal physiological pit in which the infraspinatus insert. So just make your measurement at the level of the cricoid. Once you see a bony depression on that side. Yeah.
Um, Next question is with Molyneux lines not disrupt in anterior dislocation.
Yes. So basically, Maloney line was seen, according to the literature, in cases of posterior dislocation, pretty much like when we talk about Shenton line and the pelvis.
Right. Then somebody wants you to explain about the Latarjet procedure.
Yes. Okay. So letter J, what we do basically that's done when remember when we said anterior dislocation, could it happen association with glenoid fracture? That's what we call Bankart, Hill-Sachs, posterior lateral aspect of the humeral head. Now, for glenoid fracture, if I had more than 25% of loss of the bone, or let's say 20%, then we need to make this joint stable. What do? We need to do filling. One of the common things they do is they remove the cricoid does with its attachment, and with screws they would um, um, screw it or pin it into the defective part of the glenoid. I can go back to the would you like me to go back to show it?
Yeah, sure, you can show them.
Kind of screen is stuck. Let's see where it was here. Yeah, so as you can see in this example, so they take part of the cricoid and it's chopped off without its attachment, and then with the screw it's basically pinned to the bony defect or bony loss of the glenoid. Is that
Yes.
okay?
Uh, so the last question for the day is, can you see a Hill-Sachs lesion without a Pancart's lesion?
Yes, because we talked earlier about engaging, not engaging, right? And that's why we have to measure it. But sometimes there could be zero loss of the bony bankard. Yes, we can see that definitely.
Okay. I think that kind of sums up the Q&A as well. Thank you so much for such an amazing session. And
Thank
I think we
you.
are pretty excited for already for the next session. So we'll have you back soon. Thank you. Thank you once again. Thank you everyone for attending.
Thank you very much for the kind invitation and thank you for the questions. If you like, you can share my emails, my email if for like to answer further questions if you like. I mean, if we could not take them today.
Yeah, so you can put that into the chat box. Then everybody can read them out, read it out.
Sure, sure. Can you see it?
Right now,
Oh,
no,
oh, yeah,
because you
sorry.
have
Let me
to
just.
share it to everyone for everyone to
Oh,
see.
yeah, you're right. Okay. Sorry for the caps.
Yep, we can see it now. So, guys, if you have, so everyone just you can note down her email ID. So, if you have any more queries or something, you can directly mail it to her. Right, Narola, that won't be bothersome.
Perfect. Thank you so much.
Thank you. Thank you so much.
Thank you.